Welcome to another episode of the Imperial Sports Knee Meeting podcast. My name is Ernest, and I'm going to be your host for today. Today's episode is all about choosing the right ACL graft for your patient, and I'm very honored to be able to have this discussion with Mr. Rahul Bhattacharyya, who's a knee surgeon that's based in Glasgow, but also an honorary clinical senior lecturer at Imperial College, London. Mr. Bhattacharya serves on the executive committee of the British Association for Surgery of the Knee. This is my conversation with Mr. Bhattacharya. Hi, Mr. Bhattacharya. Welcome to the Imperial Sports Knee Meeting podcast. It's really good to have you here. How are you?
Very good, Ernest. Listen, thank you very much for the invite, and I'm really excited to do this podcast with you, and looking forward to it. I'm doing very well. Hope you're good too.
Yeah, it's been brilliant. So let's just dive straight in and talk about ACL graft choices. But before I go into there, can you just explain to our audience why does the ACL matter? What's so important about it?
Look, the ACL is a really important ligament in the knee. It's an intra-articular ligament, and the reason why it's important is plays two really important functions. One, prevents anterior translation of the tibia on the femur, and two, it controls internal rotation of the tibia. Now, it's important to understand from a biomechanical perspective, actually, when it comes to internal rotation, it's not just the ACL. The anterolateral structures of the knee play a really important role. For example, so a lot of research been done in the Imperial Biomechanics lab, and they've shown the iliotibial band plays a more important role than the ACL when it controls internal rotation, particularly in deeper knee flexion. So those concepts are important, and that is why when you rupture an ACL, the knee is unstable. So patients have instability in two planes. They're lax on the anterior posterior plane, but also lax in the rotational plane because of two reasons. One, contribution of the ACL to the internal rotation, but also because often with an ACL injury, there are associated injuries to the anterolateral structures, including capsule and the IT band. So then patients who are young and active who want to go back to playing high pivoting sport or lead an active lifestyle in general find it really difficult to live without a functioning ACL because their knee, they can't trust it. They're rotationally unstable. Any quick sudden change of directions, their knee gives way. And, the apprehension is too much for them to really do the things that they want to enjoy doing. And when we look at higher level sports, like professional athletes, for example, ACL is absolutely key. So and it's a common injury, say, for example, in footballers and hockey players, skiers, netball players, and when they tear it, without a reconstruction, without surgery, they find it really hard to go back to their sport, this is the reason why it is such an important ligament and one we spend a lot of our time thinking about and then, seeing patients with these injuries and then treating them.
And in your practice, what are really the key factors in a patient's history that you particularly look out for when you're assessing a patient's ACL injury?
So the first thing, Ernest, is the mechanism of injury, and when they've had it. So the timelines are really important. If they come to see me in clinic, I need to know how they did it, what was their course of events at the start, and how long they are now from the time of injury, what their current symptoms are. And when I focus on current symptoms, I focus on four key areas. One, instability, subjective instability. Ask some simple questions. If they're walking in a straight line, change sudden directions, do they feel like their knee is going to give way? Do they avoid doing certain things because of apprehension of knee instability? Next thing is pain. Do they get any pain around the knee? Mechanical symptoms. Do they get any clicking and catching? Because often with ACLs or associated injuries, such as meniscal injuries, it's important to tease that out from the history. And then finally, swelling. Do they have a lot of swelling to start with? Did the swelling gradually settle down? And that also depends on the timeline. So that's really important to understand all of those features because, the clinical picture in soft tissue knee injuries, both the history and clinical examination is key. It forms 80% of my decision making. The final 20% is the imaging and the MRI that corroborates what your clinical suspicions are. It's not the other way around. That's really important to understand. The next things in the history are you need to know about the patient, what the patient is like, what's their age, what their activity levels are. If they play sports, is that a professional level? Is that as a hobby? Or what type of sports they play? And then you dive further into their daily activities. For example, do they do a lot of kneeling? And that then ties in with graft choices, as we will discuss later on. General history, general health, hyperlaxity, if they're known to have any other medical conditions that will influence your decision making in their case. That's really important. So we go through all of that in the history as well. And then finally, you want to know what they want to get out of their knee and their future aspirations. And we discuss that before we move on to the clinical examination.
And I've always heard in training that not everyone requires an ACL reconstruction. Is that still true?
It is. So it doesn't mean that if you have an ACL injury that you will have to have ACL reconstruction. But that is where this whole concept of personalizing treatment to the patient. If somebody is not very high demand, older in age, not really going to do anything pivoting, they're predominantly just looking at walking as their main day-to-day activity, they may not need an ACL reconstruction. For them, physiotherapy, building the strength of the muscles around the knee may be enough, to go through with their day-to-day activities. So, not everybody needs to have ACL reconstruction. That is absolutely true. This is where the history, clinical examination, personalizing the treatment to the patient is absolutely critical.
And I think because this is a surgical podcast and we are all surgeons, we're going to talk about operations, isn't it? And
Absolutely.
we're going exactly. And we're going to come on to this part right now, which we are going to talk about the different graft choices that you have for ACL reconstructions. So Mr. Bhattacharya, can you tell me about what are the graft choices?
Yeah. So when they think about ACL reconstruction, there are lots of different graft choices, and we categorize them into different things. So autograft, where you take the graft from the patient's own tissues, allograft, which is grafts coming from cadaveric donors, and also synthetic grafts is something that's been talked about. Now, in my practice, I just want to put it out there before we go into further details of the graft choices. I do not use a synthetic graft for any ACL reconstruction surgery. There is some role of synthetic grafts in the extra-articular ligaments. There's been growing interest to looking at the medial side, even the lateral side, but certainly not for ACL surgery. Now, coming back to the other two main broad categories, we've got autografts and allografts. With autografts, patient's own tissue, there are three really main options that we have that I use in my practice. Got hamstrings autograft, and I think hamstrings is a great choice. There is a lot of literature and people quoting failure rates with hamstrings. So I think the problem with those literature data is very heterogeneous. So they club everything together. There's various ways and techniques of doing hamstring ACL reconstruction. I think in the modern day, with the technique I prefer, for example, which is a single tendon semitendinosus, when you fourfold it or quadruple it, you get a really thick graft. I mean, the patients I treat in Scotland, my main graft diameter is 9.5. Often it's 10. So you get a really predictable graft size, actually. So the less predictability is not that applicable, but in certain populations it may be. So that's why you have to know what population you're treating. And then with the quadruple semitendinosus and the dual tensionable buttons, you can really get a predictable tension in the graft, and with the addition of modern augmentation, which we're going to go later on with lateral tenodesis, it is actually a really, really good construct. So therefore, hamstrings in my practice, for the regular patient who gets an ACL tear who are active, I use that a lot. I would say 60% of my ACL reconstructions are hamstring autograft, single tendon, quadruple semi-T. Then we got bone patella tendon bone. Another really important graft, really strong, really good graft for ACL surgery. Why? Because you get two bone plugs on either side and you get the patella ligament in between. So it's ideal, right? Because you've got two bony tunnels, you've got two bone plugs to sit in those bony tunnels. So you get bone and bone healing, and you've got the ligament in between. So, if you look at it conceptually, it is a great choice, and it is. But there are risks with everything. Patella tendon ACL reconstruction has got its own risks, probably a bit more donor side morbidity and risk compared to hamstrings, such as, it's very rare, thankfully, but you can have problems with the patella tendon rupturing or getting patella fractures if, technically you've not done it perfectly. So it is important to understand that and give patients that information so that they can make an informed choice. Counseling the patients on this is really, really key. However, patella tendon grafts are, again, great for example, professional athletes. And I'll come to the individualized algorithm for when I make my decisions in a minute, once I've mentioned all the grafts. But patella tendon is a very good graft. And then the next one's quadriceps. Quadriceps has become more common in the recent times. There is a lot of vogue to using it, a lot of people, using it more in recent time because there is data now coming out. However, there is still the long-term follow-up issue. We do not have long-term data as much for quadriceps tendons as compared to hamstrings or bone, patella tendon, bone. But again, the pros or the advantages with a quads tendon ACL is you can get a lot of collagen tissue. You can get a thick graft. It is predictable in the quad tendon. You could, once you know the course in which the quad tendon runs and you have a good harvest, and there are certain pitfalls technically, as with anything, but if you get a good harvest, you can get really good collagen in that graft. And because nowadays, again, with the dual adjustable buttons, you do not need a long graft. It's a short stiff construct. So if you get a 6.57 centimeter length quadriceps graft, it is a really good choice for ACL reconstruction. So again, another good autograft tissue. And the other flexibility you get with quads is you could even take it with a bone block. If you wanted to increase the length, you can take bone block of the patella, flip it over, use that on the femoral tunnel, and use soft tissue fixation on the tibia. So again, really, really good choice. So those are your main sort of broad autograft options. In my practice, I would say 60% hamstrings, 30% bone, patella tendon, bone, and 10% quads. And I'll come to my algorithm in a minute. The other option is allograft. Allograft is tendons or tissue that you get from a cadaveric donor. Now, you have to be careful when you use allograft in primary ACL surgery. There are a lot of evidence, systematic reviews that showed failure rates up to 25% if you use it in younger active patients. So I do not use it in young active patients. However, if you have somebody older, for example, scenario, somebody 50 plus, woman, for example, and then their own hamstrings may not be of great quality at that stage. They may not want to have a bone, patella tendon, bone at that age. A allograft is a good option for them. And nowadays we get really good allografts, really well prepared, strong tissue, predictable. So yes, certainly in that population, it is a great choice. And also a choice in revision scenarios, and multi-ligaments. I use a lot of allografts in my practice, again, for the collateral ligaments, from the medial side, for the posterolateral corner. I use it for PCLs. So there is a big role for allografts in multi-ligament knee surgery and for ACLs, as I've mentioned. So those are the graft choices, Ernest.
Some of the audiences that might be listening might say, hang on, there are a few other rarer types of graft choices, like the peroneus longus graft.
Yeah.
Is that something that we use here in the UK very often?
Really good question. Look, in the UK, the use of peroneus longus is not common. In my entire time training and now practicing as a consultant and a sports knee specialist, I have never used the peroneus longus graft. I've never really spoken to anybody else, mainstream sports knee surgeons in the UK using this graft. But there has been a lot of, literature coming from the Asian countries. I know in Pakistan, they've been using peroneus longus. We were privileged to have one of their consultants, the president of the Pakistan Knee Society, who came over as part of the BOA Basque session last year and spoke about the peroneus graft. They have had good results, minimal donor site morbidity, although something personally that worries me when you take the peroneus longus, how that affects the ankle afterwards, nerve that is there, the superficial peroneal nerve, what is the risk of injuring it? I don't have the experience. I'm not really qualified to say more about it, but what I can see is there is some literature there. And in some countries where maybe access to allografts is not as easy, financially, it gives them more options, again, in a primary scenario or also in the multi-ligament scenario. So something to keep in mind, something to keep your eyes out and see. But, I'm always skeptical with new things. You need to make sure the due diligence is done. Good biomechanical studies, high quality clinical data before you bring it into your practice and offer it to your patients. So to watch the space, essentially, is what I would say for that.
Yeah, thank you for that. And you did a really nice explanation on the common grafts that are being used in the UK. And this episode is going to be talking about personalizing these graphs. So what do you mean by that? What does a personalized graph mean?
Really good question, Ernest. Look, my belief is in 2025, in today's day of ACL reconstruction surgery, we should be able to do technically all the grafts, and we should be able to speak to the patients about the risks and benefits of each graft so that they can make an educated or an informed choice. I think that is important, and that's how you personalize it. So for example, in my practice, I'll give you a scenario. I said 60% hamstrings I use, okay? So vast majority of young active patients who come through to me who get an ACL there who are not professional sportsmen, who do not have a medial-sided injury. That is really important for me because if you look at the biomechanics and the science, particularly the semitendinosus has got really strong vinculae attachment to the medial head of gastroc, and these are dynamic stabilizers of the medial side of the knee. So if you take these out, when you harvest the hamstrings, that can cause or add to medial instability. So that's one contraindication for me. So if they don't have a medial-sided injury, I would use a hamstring. I would offer a hamstring graft to them, and then tell them my technique and the pros and cons. Now, there's slight cons to it. Every graft has a donor-side morbidity. Hamstring's probably got the least, but you can get a saphenous nerve injury, so it's important for them to know this and understand it. And also, for example, they can get a little bit of flexion weakness. However, by taking just one tendon, you can minimize that. So if certain group of people like sprinters, you should be careful offering a hamstring graft to them because that flexion weakness may be a real problem for them. Okay, so this is where the personalized aspect comes in. Okay, so you tell them that these are the situations where I use it, but importantly point out the situations that you don't want to use it, and then give them the risks and benefits and make them do an informed choice. Now, here I also, whenever I talk about hamstring ACL, I quote the stability trial data, randomized controlled trial, level 1 evidence, international study led by Alan Gedgod and team. And they have shown that with hamstring tendon ACL reconstruction, additional lateral tenodesis, and we'll come to lateral tenodesis separately later on in this podcast, you can bring the graft re-rupture rates down in the hamstring group from 11% to 4%. So you can get it to under 5%, which is really good. So that is my hamstring group. Now, when it comes to bone, patella tendon bone, for all the professional sports people, particularly the professional ground sports people, for example, football, hockey, I do offer BTB as the first choice. Why? Because there is data from the professional sports world. I mean, if you look at Andy Williams' series, he has shown that with a bone patella tendon, bone ACL, addition of lateral extra-articular tenodesis, and using the anteromedial bundle as the tunnel position, you can bring the graft re-rupture down to 2%. I mean, that's incredible, right? In a high-risk group, patients who are playing professional sport, if you can bring that down to 2%, and there is good data from a group that is doing high numbers in pro sports, to me, it seems like that's something to follow. So therefore, I offered that to my pro sports, and I've got pro sports practice as well, not to the extent that these guys are doing, but a certain proportion of my practice is professional sport, and I would offer them a bone patella tendon bone. So that would be my first indication. Patients who've got significant hyperlaxity, bone patella tendon bone's a great choice. You've got bone blocks, and it's a more robust graft in that scenario as opposed to a hamstring tendon. So that'll be my second indication. Third would be revision ACL reconstruction when the primary was a soft tissue graft. Okay, so those are really the main areas where I use bone patella tendon bone. But again, you have to inform patients of the risks. Patients with bone patella tendon bone can get anterior knee pain after surgery. The rates of this is variable. If this is and more historic, if you see in the past when people harvested BTBs, they took a lot of the fat pad, and therefore it was a much more aggressive way of harvesting, so the rates of BTB anterior knee pain were much higher. Nowadays, with better tools, with better techniques, and look, I've only done it in recent times, and this is talking to people who have done BTBs 20 years ago, it seems like that the techniques have evolved to the point where that risk is much lesser. In my cohort that I've done, I've not had many with anterior knee pain. But if you look at quoted literature, it varies from 5% to 48%. So there is a risk, and patients need to know that. So if some people really depend on their daily activities, depend on kneeling for their daily activities, for example, electricians, plumbers, these group of people, or people for religious reasons that they're kneeling, they need to know that this may be a problem and may not be the best graft for them. So I would explain that to them as well. And also jumping athletes. Jumping athletes, BTB may be a problem. Basketball players, netballers. So they need to know. So this is where, again, personalizing, tailoring the treatment to the patients, giving them the scenarios, the pros and cons, the risk versus benefit, and then letting them make the choice. And then when I come to quads, in my practice, I use it the least out of the three, but look, it is a very good soft tissue graft, and I use it in the primary scenario if patients have got that associated medial-sided injury. I offer them quads if they don't want a BTB. So quads, BTB are both options for them. In multi-ligament knees, really good choice. So I've done it in multi-ligament where I use the quads for their ACL. If they've had an associated MCL injury, I don't take the hamstrings and use allografts for the elder sides or synthetics for the extra-articular stuff. So that's another area where you can use quads. And also for the revision ACL scenario as well, it gives you a great choice. Again, with good harvesting, you can get predictable diameter, predictable length, really good volume collagen, dual adjustable buttons, predictable construct. So I give that. So those are my real decision-making pointers for these grafts. And then allografts I briefly mentioned already. If patients are, in the revision scenario or multi-ligament knee situation, or if they're elderly women above 50 for the primary ACL. So that's how I personalize it so that the patients can make the informed choice.
That's such a comprehensive way to just put the whole thing together. And if you allow me to be just a little bit controversial,
yeah, of course.
That's
just the whole point. Yes.
Considering quadricep tendon grafts and your bone patella bone grafts, one might argue that if the bone patella bone graft gives someone anterior knee pain, why don't we just use, and yes, we can get bone-to-bone fixation within the tibia and the femur as well. And you can still take a bone plug for a quadriceps graft.
Yeah.
Why not just use a quadriceps graft? Why would you still use a bone patella bone graft?
Look, very good question. Two reasons, right? One, data, science, evidence, really important. Bone patella tendon bone has been there for years. There is really good long-term follow-up data to show that they work, and they work very well. That is supported by registry data, so high volume, high numbers. It is supported by single series, like I just mentioned, in professional athletes. So if you have something that has got science behind it, clinical data behind it, biomechanics to support it, it's a no-brainer to use it, really. Now, from a logical perspective or common sense, yes, quads is a good alternative, I agree. But you don't have bone blocks on either side. It's bone blocks on one side, so you still get soft tissue fixation on one side. If you really are a believer on that bone-on-bone healing, then why not use it on both sides? Quads doesn't offer that, BTB does. And then the longer-term data for quad, we need to really watch the space. If there is a study in future to compare the two, higher-level clinical evidence, randomized controlled trial. And look, this is where we are awaiting the results of Stability 2, which is the follow-on from the Stability 1 trial. Now, that is a multi-center international randomized controlled trial. Again, Al Gadgood's team leads it. He will be in our ISCM meeting coming up in January next year. And I think he's going to probably, the data will be out in the next year to 18 months, I think. I don't know the exact timelines, but that'll give us a really good idea as to how quads compares with BTB from a clinical perspective. And we'll know the answer. But no, very good question, and certainly an option, no doubt about that.
Do you ever find with quads tendon grafts that, the patients, especially because you've harvested their quads tendon, they actually struggle to get that extension back post-operatively? Could that be one of the reasons why you would choose a BTB over quads, for example?
Good question again, and it's like, look, this depends on their post-operative rehab. Now, I think in the UK, we do see a problem with that because I don't think we use as much quads as, for example, America. So look, the success of an operation is not just technically what you do as a surgeon. It is really dependent also on your team. Rehab is so critical. I work very closely with my sports physios when I treat the athletes. And I think that, and also the regular patient, you have to really work closely with your physios to ensure that their rehab is good and they get the best outcome. And I think when it comes to quads ACLs, our rehab teams are not as, experienced with it as compared to the States. So in the beginning, they do get weakness in their quads. They get a higher rate of what we call arthrogenic muscle inhibition. When a knee gets an injury or surgery, there is good data now to show that this is driven from the primary motor cortex in the brain. And that inhibits the quads and reflexly contracts the hamstrings, okay? And they've got different grades. And this can progress to just, having some weakness in the quads to getting an extension deficit where the hamstrings overpower the quads, and that may not resolve with just simple physio exercises. And that is important because with quads patients, there may be a higher rate of AMI as compared to BTB or hamstrings, okay? So the physios need to know how to treat that in the initial phase. The initial phase certainly a bit slower, I think, in their recovery the first 6 weeks or so as compared to the other two grafts. So that is an important consideration, one that the patients need to know as well. And I often would counsel that as part of my graft choice talk that I have with them.
Thank you so much for that. I think we get a flavor of how complex, but also how interesting this space is, especially with the data that's out there and what you pick. And I think probably for our audience to bring everything together, it might be good to discuss a few cases.
Absolutely, Anis.
Yeah, shall we do that? So I think we've got two cases planned. So the first one is someone that I've actually came across in my clinic before. So this is an 18-year-old ballerina dancer. Three months ago, she had an incident where she was performing with a colleague, and they did a certain maneuver. She twisted her knee, she fell, immediate knee swelling. The short of it is that she comes through the emergency department and eventually presents to you 6 weeks down the line from this injury.
Yeah.
She's already had an MRI scan done, which shows not just a mid-substance ACL rupture, but she's also got a lateral bucket handle meniscus tear.
Yeah.
Horrible injury for an 18-year-old.
Yeah, absolutely.
So you examine her. She's got no postural medial instability, no postural lateral instability. She extends to neutral, but she can only flex to about 80 to 90 at a push. Okay. How would you approach a scenario like that? I think this is something very common for a registrar that sees someone like that in clinic.
Yeah. So very interesting case, Ernest. Look, nasty injury for the patient, no doubt about that. 6 weeks down the line, you're telling me she's not locked. She's got full extension back. She's got a bucket handle lateral meniscus tear with an ACL tear. She's a high performing athlete as a ballerina, but she's not fully flexing her knee. Okay, so the decision making here really is a timing of surgery, whether you stage it or not. Now, if she's not locked and she's 6 weeks down the line, I wouldn't do a staged operation. I would try to do a single stage lateral meniscus repair for the bucket handle tear, preserve the meniscus for her, and then do an ACL reconstruction at the same stage. And there is a lot of evidence now to show that obviously the meniscal repair healing is higher when you do a concomitant ACL reconstruction. But at this stage, at 6 weeks, if she's not got full flexion back, then probably not the ideal time still to go in with surgery, because it's important for them to get the full range back and the quad to fire so that their risk of stiffness afterwards is lower. But then you have to also balance it with the fact you don't want to delay too much, because chances of repair healing from the meniscus becomes lower. So my primary thing here would be to work with a really good physio in the first instance, give them next 4 weeks to get the flexion back, and plan for surgery really in the next 4 to 6 weeks once she's got full range back, full extension, full flexion, the quads are firing. If she gets that back out, my plan would be to do a single stage lateral meniscus repair, ACL reconstruction, and augment it on the lateral side with lateral extra-articular tenodesis. Now, again, here, personalizing graft choices to the patient, really important. So, I would discuss with her the different graft choices. She's an 18-year-old female high-performing athlete. My primary graft choice for her would be bone patella tendon bone. Again, that bone and bone healing, robust graft with the addition of the LET, AM bundle, femoral tunnel, good tunnel location in the tibia, proper fixation on either side. I think, and a lateral meniscus repair, her chances of success are the highest. But then she needs to know about, there are a few considerations here as well. Now, sometimes with a young woman, the patellar tendon may not be wide enough. The patella itself may be very narrow. You really don't want to take more than the central third of width when you do a patellar tendon harvest. Because if you do, that's when I think you can increase the risk of those catastrophic complications. Patellar tendon rupture, patella fracture. So I would often measure it on their MRI. If their graft diameter is 25 or under, there's really no point in taking an 8mm patella tendon graft. I think that's very, very narrow, and you have risk the bone blocks being really small as well. So in that scenario, I'd offer a quad tendon autograft. Again, predictable diameter, that would be a good alternative for her. And I would explain those two options, pros and cons, and then, look at her anatomy and see which one fits best. and then give her all the other considerations I gave you previously in this podcast so that she can make an informed decision. I think hamstrings is less likely for her because, again, the length may be unpredictable, the diameter may be unpredictable. And, at her really high performing level, as you mentioned for this young girl, probably the failure rate is higher. Again, there is no comparative level 1 data, but at least from the registry data, albeit it is heterogeneous, but from the current evidence, primary choice BTB, secondary choice quads based on her anatomy.
Yeah, I think that's a very full view of how personalizing the graft to her is really important. I think what you haven't mentioned as well is actually you've understood what she goes through. Like, being able to actually use her knee in certain ways actually determined which graft you would choose for her. And I think certainly for me and my colleagues who are in this kind of acute knee clinic setting, it's very important to find out really what level of performance she's actually at and what her goals are. So the interesting thing about this girl is that she was actually in a very difficult time of her life. So when she had this injury, she was actually auditioning to get into one of the very competitive ballet schools. And that changes everything, isn't it? This is someone who needs to get back quicker. And our clinic sort of appointment at 6 weeks was not so much about discussing about grafts, but it was discussing about how fast she can get back to what she does. And then it went on to whether
That's what I was saying with the history, right? So, when I was answering a question, I was really focusing on the surgical side here and options because, tailing in the graft choices, but history really important. This is why I was saying you have to understand the patient, what's their level of, ballet that they do. Like you say, she's going back into competition. So for her, that really dominates her psychology. And it's really important to tease that out and understand and go through that discussion with her so that she's happy with, what options she's selecting, what her return to play timelines look like. Look, it's important for them to understand that ultimately she will be out of high level competition for 9 to 12 months. And there is no way around that. And it's important that they really get that in the initial consultation because that will help them go through psychologically with what is a long rehab. And that determines success as well. So yeah, that's a point well made, Ernest. Very important. As I said, history, clinical examination key. And that's where you tease out all the information. You need to spend time with these patients. These are not 5-10 minute consultations. You need time. I often book half an hour for these patients to make sure that I can discuss everything in detail.
Yeah. So thanks for that. That was really insightful from you. Do you have any cases that you want to discuss as well that for personalized graft choice?
Yes, Ernest. I think there's one case which, again, illustrates, how you really tailor this, and brings everything together, what I've just mentioned. So I've had a patient recently who is 31, or very active, gym goer, who is about 9 months down the line from the injury, who's got an ACL tear, a medial meniscus tear, but also has got a deep MCL injury, and clinically has got anteromedial rotatory instability, which is what we understand more and more of nowadays. So clinically has got the anteromedial rotation more than the other side, a positive dial, which is coming from the anteromedial side rather than the posterolateral side. And he's not keen on having a BTB, for example, in this scenario because he kneels a lot in his personal training job that he also does on the side. So this is a scenario where you don't want to take hamstrings because, again, that medial stabilizer, so you don't want to take the semitendinosus, which has got those vencular attachments to the medial heterogastric. So when I discussed different choices and pros and cons, he was very happy to have a quadriceps tendon in this scenario. So this is where, again, you can really look at those associated injuries, look at the medial side. Important to pick up subtle clinical signs because he doesn't have valgus instability. He doesn't have a superficial MCR injury. So this is where, again, picking up clinically, going through both their history points, the examination points, then look at the MRI and tailor the different choices. So here, quads is a great option, and that's what he went with. So just wanted to mention this as, an additional real-life case scenario to tie in with the chat we've already had with personalizing graft choice and ACL surgery.
Yeah, maybe let me just kind of dive into that a little bit more specifically. So some of our listeners might have completely missed it. What is the significance of that anteromedial rotatory instability and harvesting the hamstrings again? Like, why is that so important?
So look, hamstrings, there is a school of thought that hamstrings are a dynamic stabilizer on the medial side. So on the medial side, with the semitendinosus having those vincular attachments to the medial head of gastroc, this acts as a stabilizer. So if you take this graft, there is a thought that you could worsen their anteromedial rotatory instability, can contribute to the instability. So therefore, it is not good for that injury, although the graft itself may still be good for the patient, but it's not good for the medial-sided injury. So that is why you want to avoid taking the hamstrings in that scenario. So then you're left with the other two choices, and then you discuss pros and cons for bone patella tendon bone versus quads.
That's great. Thank you so much for elaborating on that. I think just to round this part of the episode off.
Yeah.
In my training, I've always heard this term, which is the bone patella bone graft is the gold standard graft.
Yeah.
I'm gonna ask you probably to take a stance on this, but do you still think that do you still think that statement still applies in 2025?
I have a problem with the term gold standard. Like the whole discussion we've just had is personalizing to the patient their needs. When you say gold standard, you automatically say something is better than the others, and therefore everybody should have that. If it's a gold standard, you should give it to everybody, right? But that's not what we discussed. I think in 2025, there is a place for all of these grafts in the correct patient, according to me. And therefore, I wouldn't say it's gold standard. I would, have a problem with labeling it like that. It's a great graft. We said why it's a great graft. For the ACL, it works perfectly when you think about the science, the anatomy, the high level athletes. But it's got its problems. For some patients, it may not be good. For the patients who are kneeling, for example, if they get anterior knee pain, that is life changing. So for them, it may not be gold standard, right? So therefore, again, in 2025, the gold standard is to personalize the different grafts for the patient.
I think that's such a good summary of everything that we've discussed. And I think we're coming to the end of this episode. But I want to talk very, very slightly about the LET, the Lateral Extra-articular Tenodesis. Just for our listeners out there that actually don't know what that is, very briefly, what is it and why does it matter?
Okay. Look, again, lateral extra-articular tenodesis really come back into prominence after the results of the stability trial were published. This was 2020, AJSM, level 1 evidence to show that when you add it to hamstring ACL reconstruction, you significantly reduce the re-rupture rate, as we discussed before, from 11% to 4%. What it is taking a strip of the iliotibial band, which is on the lateral side of the knee, and as we discussed, it is very important controlling the internal rotation of the tibia and the femur. So we take in my practice, I take a 1 centimeter wide strip, approximately 10 centimeters long. I take it from the posterior half of the iliotibial band, ensuring that the capillin fibers are still intact. And then I take it underneath the lateral collateral ligament, and that is important. There's work done in the Imperial Biomechanics lab, again, published data to show that if you take it underneath the lateral collateral ligament, where the lateral collateral ligament attaches to the lateral epicondyle, it has a pulley effect. So it creates an environment of favorable isometry, but that actually gives you flexible insertion points in the femur. So my preference, for example, is to insert it above or proximal to my femoral ACL tunnel. So then I'm not worried about tunnel coalescence or convergence at all, okay? So it gives you flexibility if you go under the LCL. So that's really what LET is. You fix it then above or, on the distal femur at your preferred point. There are different techniques, modified Lemaire, McIntosh, and, that's more detailed. We're not really diving into that in this podcast, but you fix it at an appropriate point. And the idea is it reduces the rate of re-rupture of your ACL graft. So it is like a seatbelt for your ACL graft. What are my indications? So I use a lateral tenodesis for any patients that I'm worried about, really. So patients under 25 years of age, patients who have a high-grade pivot at EUA, patients who are returning to high-grade pivoting sport, patients with hyperlaxity, patients with hyperextension recurvatum, all my revision ACLs, and patients with increased posterior tibial slope as well. In the primary setting, you don't really then need to do a slope change osteotomy or anything. In primary setting, you're adding LET. So all of these groups, these indications, I would add a lateral extra-articular tenodesis. And, and the interesting thing is LET is not new. This is not a sudden new discovery. If you look at the history, Lemaire wrote about this in 1967. McIntosh had a modification published in 1979. Then Elson did a tibial-based LET in the 80s. But the problem historically was that people were using LET isolated, so weren't doing an ACL with it. And often, therefore, they were immobilizing the patients for a prolonged period of time, and the result being increased risk of lateral knee osteoarthritis. So it fell out of favor. But if you combine it and get the patients going early in terms of the rehab and tailor the rehab, I think it's really, really powerful. So therefore, most people's practice now, LET forms a really, really important part, in terms of having a lateral augment or a lateral extra-articular procedure, what we call LEAP, which the other part is ALL reconstruction. There's some people who use the ALL. It's not as common in the UK, and there's a lot of data coming out of France, particularly from the Santi group. High numbers, ALL reconstruction works. So, it is a choice as well. But my personal preference is to do an LET.
That's such a great summary. Maybe just to end off this section, one might ask, why wouldn't you just do an LET for everyone?
Good question. Now, again, personalizing treatment to the patient, right? Not everybody needs an LET. So if you get a patient who is in their 40s, who are not terribly high demand, but still want to go back to doing some active fitness type activity, so they want an ACL reconstruction, you don't necessarily need to do an LET because everything has its risks, right? LET is an extra operation. It has got a certain, risk of wound complications, hematoma, etc. So it doesn't come without its risks. And also, if you technically don't tension it properly, if you over constrain it, then there's a risk of getting patellofemoral osteoarthritis or lateral-sided osteoarthritis. So far, most of the data that's come out or even the MRI studies show that it is safe and doesn't have a long-term implication. But look, the numbers have only recently increased in the last 5-7 years. We still need to see what the long-term follow-up of this is in 15, 20 years. So you still have to have, that thought of, one size doesn't fit all. You just got to personalize it and just got to see the patient that's in front of you. So I wouldn't do it for everybody, but 80% of my practice is young, active individuals, and 80% of my patients at the moment are probably getting an LET. So it is high for me. But again, that depends on the type of patients you're treating in your practice.
That's great. Now, maybe just to end off the episode, what are the 3 things you would tell a registrar that has started on the rotation with you about personalizing ACL grafts, just to kind of put it all together for our audience?
The 3 things I would say is really, first thing is understanding the importance of history, clinical examination, really understanding the patient in front of you. Modern times, with the more and more use of imaging and MRI scans, a lot of people jump straight to the MRI, look at there's an ACL tear, in their mind already decide the patient needs an ACL reconstruction. But the importance of teasing out the history, understanding what the patient's needs are, the type of patient that you have in front of you, and then clinically picking out the signs that are important for an ACL tear and associated injuries, meniscal injuries, medial side, lateral side, really important to pick those out. So that's the first thing I would say. Understand the importance of history taking and clinical examination. The second thing is understand the fact that there are multiple graft choices available, and you need to know technically how to be able to harvest them safely so that you can offer it to the patients. So the training for a registrar to get that is important so that they, if they want to be a sports knee surgeon, ensure they work with people who are doing high volume ACL reconstruction so that they could get exposure to all of these techniques. And then number 3, the importance of the lateral extra-articular procedures. In today's day and age, understand that it is there, understand the indications for it, and understand technically how you can do it safely and well. So I would give them those 3 points.
That's so good. Well, thank you for your time, Mr. Bhattacharya. That was a very comprehensive rundown on graft choices in ACLs and a little bit on the side about LETs as well. So thank you so much. And thank you for giving us your time on the podcast.
Ernest, it's been a pleasure, and well done again on running this, and look forward to catching up with you soon. Thank you, and hope the audience finds this useful.
Yeah, we'll catch up soon.
Thank you, Ernest.